Hello, everyone. My name is Dr. Julie Bishop, and I'm a shoulder surgeon at The Ohio State University. And today we're going to go through the bone block cerclage technique for anterior and posterior glenoid bone loss. And first, we're going to talk about what you'll have on the back table. There is a glenoid bone loss convenience kit that has everything you need for disposable and usable and necessary implants. And we use this kit to have an easy and reproducible surgical technique. The kit has a measuring probe that helps you measure the depth and the size of your bone block. We have two 3mm cannulated drills of different lengths to facilitate your unobstructed drilling. There's a megaloader that you can use to aid the passage of your sutures into the instruments and the bone block. So this is the anatomically curved aiming guide. We'll be using this for our anterior bone block. There is a scallop right here that you can see, and this helps it lie flush and compress on the glenoid face. There's a 10-degree safety angle that prevents your drills from going further than you'd like. It's incorporated into the shaft. You have to make sure this guide lies flush on the entire glenoid. And then you can see there are two marks right here to help you decide whether your depth is 5 millimeters or 7 millimeters. You can see that there's laser marks, and this lets you know the trajectory of your drill bits, so you have an understanding of where they're going to exit the face of the anterior scapula. So this is the drill sleeve that you'll use to go inside of the guide, and based on what you determined from when you place the guide in, whether you wanted 5 millimeters or you can see on the other side 7 millimeters. For this case, we've chosen 7 millimeters, so this is the way we place this with the 7 up, and it goes into the guide. And then you can see here that there's a ratcheting function, and this right here will be snug against the posterior scapula, and you'll ratchet this up until it's nice and snug, and then you can see this is the depth of how far your drill bit will go based on 5 or 7, whether it goes to this notch or this notch. Okay, so now we're getting in position to make our portals. First, we have a left shoulder. We are in the lateral decubitus position, and although I know many people do labral repairs in beach chair, I truly find, especially for a bone block, that lateral gives you the exposure you need to get as low to get your bone block in, so I do prefer. We mark out all of our landmarks as we always do, so we mark out the acromion and the navisor portal and the AC joint just to help us understand the acromial morphology. And then in the front of the shoulder, we do really our standard anterior inferior portal. This is what I use for a bank art repair, and I start with a larger cannula here for working. The standard anterior superior portal that I would use for a bank art that I can look through and look down on the face of the scapula to make sure I'm preparing it properly. And the one thing we do a little differently is our posterior portal. You can see here that we have a horizontal rather than often folks do a vertical portal. And we do a horizontal portal. It's a little more medial than normal so that you can adjust it more medial or perhaps more lateral if you need to, so that when you place your guide in, you have the best trajectory possible. Okay, so now we're going to size our defect and really just make sure that we have the proper dimensions. I will say that I typically size my defect on the CT scan ahead of time, so I know from anterior to posterior what the expected bone loss is. I have an idea of superior to inferior and medial to lateral, but always intraoperatively you want to make sure that what you do correlates. So I will, right now I'm looking anterior superior. I'm bringing in this guide from the anterior inferior portal, and you can see the 20 is up at the top, and down at the bottom is where it starts. So I do believe that from superior to inferior, this confirms we have about a 2 centimeter defect, which is pretty typical. I tend to see 2 centimeters from inferior to superior, about 1 centimeter from posterior to anterior, and then 1 to 1.5 from lateral to medial. But we just like to confirm that this is what we thought it would be. So I can see where the 10 is, and then I know I'm going to mark that area with radio frequency, so I know that's the middle of the bone block, and it should line up there when I bring it in. So once we have established all of our portals, the next step that we do, which I think is most important, I'm looking anterior superior. We first need to completely release all of the soft tissue off of the anterior scapula. Often the remaining labrum and capsule is matted down. It can be stripped and scarred down, and you have to completely release. Really here, we're all the way at the top on this left shoulder. It's 11 o'clock or so, all the way down. And I think it's imperative to actually go around the bottom. So we're actually going past 6 o'clock, because the more you've elevated this, the more room you have at the bottom for your bone block, and it won't get caught on the labrum. So first, we completely mobilize. We take our elevator or our frequency and get all the soft tissue attachments off. So we're seeing here, you can clearly see all the fibers of the subscap, and there's nothing at all attached to the anterior labrum. And I think it's important to understand that as much time as you take to execute this part and prepare this part of the surgery, when you actually are passing the bone block, it'll go better. So take time up front. Once you're prepared with your burr and you're happy with your flush cut surface, the next thing we like to do is then place a traction stitch. For this traction stitch, we went trans subscap. So we did first start with a spinal needle just inferior to our anterior portal, and then penetrated. You can use a crescent or a 90-degree lasso, and then you can pull on those sutures. So when you start to put your bone block in, we can put some tension there, and that can help us pull the labrum out of the way. At the conclusion of the case, you can use this tape if you wanted for a push lock anchor in the glenoid as one of your points of fixation to repair the labrum back to the native glenoid. Okay, so the next thing, once we're completely prepared, we have our traction suture, is we need to recheck the trajectory for our transglenoid guide. We started with our horizontal posterior portal, but you don't have to be married to that. So you can come back through that portal with a spinal needle or your switching stick and make sure that your trajectory, here's where we marked the glenoid, so we know this is the middle of where our bone block will sit. That's our little bovie mark. And what we want to see is that we are sitting flush and we are not angled this way or angled this way. And if we aren't flush, you can absolutely reposition. You can extend your incision more to one direction or the other, reposition with a switching stick so that you know when your guide comes in, it's going to sit nice and flush. So I did reposition this and I like the way it sits. So now I think it's time to bring our guide in. Okay, so now that we've determined we like this trajectory, we are going to slightly enlarge our posterior portal. So we'll take this out, and I find I typically want to go a little more medial versus lateral. So we'll just extend it a little bit, and that helps get the guide in. And then I think it's important to use, you can use a Mayo scissor, you can use a snap, just something to go down so I can actually feel my snap is hitting the posterior scapula, and then I'm threading through the infraspinatus muscle so that the guide doesn't get caught up. And once I feel pretty good about that, then we'll take the guide. Again, if you find you need to do a capsulotomy because they have a very thick posterior capsule, you can, but I find I often don't need to. And then here's our tip, and then you can see actually close up the grooves for the 5mm and the 7mm offset. And then we'll bring this over. We'll place it right where our bovie mark was. So once our drill guide is nice and flush against the glenoid, and we can see it is, then we come over and we introduce the drill sleeve, and we put the 7 up so that we know we're going to have a 7mm medial offset. And then once we feel that we're down to the scapula, so we push the guide down to the scapula, you feel the bone, then we start to click. Don't over click or over tighten. It'll cant the guide and cause your pins to come out too medial. So here we're stopped at about 25. That lets us know that the distance of the bone intraosseous from posterior to anterior is about 25mm. And then that'll help us, as you'll see when we drill, knowing when our drill is about to exit. So we'll drill first the inferior and place our short pin inferiorly, and we'll watch this come out. And we can see it's about to exit. And there we are. So now you can see that the laser marks on the drill stopped at 25, and that corresponds to what we had measured for the transglenoid guide. So now we feel confident going with our next pin, and that will be our superior pin. Again, we expect it to exit at about 25. And you want to be able to clearly see these pins exit. If you can't, you may need to clear more soft tissue anteriorly. There you go. And then you can see our pin has exited. And we see our lower pin right there. These pins should be 1 centimeter apart from each other. Okay, so now that we like the position where our pins have come out, we're going to remove our guide. So first we'll have to remove the sleeve. And then we can just twist the guide, and then to get the hook off, drop your hand down, follow it out so it's not getting caught on anything, drop down, and then out it comes. So here we can confirm I'm at 6, but there's actually a little millimeter right there. And so I feel very confident that the 7 millimeter offset works for the lower. And if we come out there, this is right at the 7. We can bring this in and do the same thing here and feel pretty good that we are 7 millimeters in. We didn't shoot too medial, and so we feel comfortable using that for our dimensions for our bone block. Okay, at this point of the case, before we pass any sutures, we want to make sure our rotator interval is wide open. So I'll pull my cannula back because I'm actually going to switch this cannula out when I'm complete here. And this is a critical part of the case because you absolutely don't want your bone block caught up in the soft tissue. So we'll open it all the way over lateral, obviously not into your biceps. And then go as medial as you can. Obviously, you're not going to go into the labrum. And as you're opening up the rotator interval, a good rule of thumb is this right here. You can tell we are at the lateral border of the conjoined tendon or the strap muscles. So this is it right here. So that really lets you know we have gotten as medial as we need to get opening this up. And you really do like to see those, and it helps you with your orientation. But once we're at that border, we know we've released here. We'll come underneath and just make sure we're through all of this tissue as well. But I think understanding where those strap muscles are is a really good anatomic orientation for yourself as well. The best test to make sure you've widely opened up your rotator interval is to actually take your index finger or your finger of choice and come down through. I can feel this area is wide open, and if you can do this, then you know you are wide open and ready to place your bone block. So once we've made sure that our anterior portal that we'll introduce the graft through is appropriately dilated, you can decide how you'd like to pass the graft. Now, some do not use any type of cannula, and it's really surgeon preference. Some will take a syringe and bivalve that. I like to use the Passport cannula, the 12 by 3 centimeter cannula, because of its ease, its flexibility, and I can modify it to do what I would like to do. So I bivalve this, I open it up with the scissors all the way down, and then you'll see when we finally introduce the graft, we will push the graft through the inner obturator as we pull the cannula out. But this gives me a nice cannula to retrieve all of my sutures, the nitinol wires, and the cerclage tapes. So now we'll insert this, and you can see our passport's in, and I'll just make this nice and flush. Obviously, this is my viewing anterior superior portal. It's pushing a little bit on the obturator, the passport, but I've got a nice shot down so that I can come down and retrieve my sutures through this passport and help prevent tangling. So now we're ready to pass our nitinol wire. So first we'll move and remove the obturator from inside of the drill. We'll pass the stout end of the nitinol. We'll pass the inferior one first, and I'm here waiting for it to come out. And we'll pull that out. And then now we'll do the superior. All right, and then I'll grab this. We just don't want them to tangle, and that's an important component as we move through this. So now that our nitinol are in, we'll remove the drill. Okay, and just make sure when you retrieve your nitinols, here's the nitinols coming out. We have an inferior and a superior. You separate them. We can see here we have one snapped away and the other snapped and pulled more superior, so they're away from each other. We have snaps on them so that when we remove the drills, we don't accidentally take the whole nitinol out the back. And then you can see in the back the same thing. We have them separated because we don't want any tangling. So we're going to pass our inferior suture first. We have our nitinol with a loop, and we have our fiber link, and we're going to pass the fiber link inferior. The end is through the loop so that we leave the loop posterior. And we'll calmly, smoothly pull this out, and then we have our fiber link passed, and then we'll snap that just so we don't tangle. So we'll snap down here. So now we'll pass our superior link, and we're going to do the tiger link on top. I remember that, tiger on top. So we will take the loop of the tiger link through the nitinol because we want one loop out the front, and the other tape link has the loop out posterior. And then we'll snap those together as well. So now we'll come to the back table. We've used our allograft workstation to cut our distal tibia to the dimensions that we already have chosen, and we have our distal tibia. And then what we've done is, first, it's important to drill from the cancellous side to the opposite side. This is the side that will be flush against the scapula. First, we know that our pins are 1 centimeter apart, so we've come to the distal tibia piece. And right here, we mark the middle of the piece. So we know that's right in the middle. And remember, our guide went right in the middle where we had made our bovie mark. So then when we come from that, we bring our ruler and we make sure that we are straight down from that 1 centimeter apart. So you can see that we're 1 centimeter apart. We use the 7 millimeter offset. So we want to make sure from the cartilage that we are 7 millimeters in. Now we're going to use, to be precise, a 1.1 millimeter wire that we can drill over with the 3 millimeter drill, so we can be as precise as possible and adjust if we need to. All right, now we like the position of the wire, so we'll take our 3 millimeter drill and drill through to the other side, and we can remove. And then we'll go and do our other pin. Now we'll drill our second 1.1 millimeter wire. And the reason, again, that we like to be slightly divergent is so that on the cortical side, we have a larger bone bridge, so that when our cerclage tapes are cinching down the bone block, they have a larger bone bridge, less chance of crushing the bone piece. And just to be sure, when you drill and you're slightly divergent, always check on the opposite side and make sure you're not too close to the edge. And when you drill your 3 millimeter tunnel, you don't feel like you might blow out the edge. So we like this, but because you're using a 1.1 wire, you can always redirect and you won't do any damage to the bone. So we like this. And now we'll drill. Okay. And then one final tip, which I think is really helpful, is you can see we have our bone block, and we've taken a purple marker and marked a thick line at the top. This will be the top of the bone block, or the superior aspect of the bone block. Every now and then when you introduce the bone block, it could flip or twist, and this keeps you oriented that you know this should be superior. So we do like to mark that with pen. And now that we like our bone block, we're ready to go past the cerclage tapes. Okay, so now we are ready to pass our tiger tape and FiberTape cerclage. So first we will unravel the same amount. So they are a single unit together, the tiger cerclage and the fiber cerclage. We'll take our fiber link out the front and we're going to pull them, guide them in together, same lengths. Bring them right out the front. And we have them the same length out the front. Gonna pull nice and easy. And you really want to pull a fair amount out so you have minimal slack in the system. And then we keep them snapped at the skin. Okay. And then we'll snap these. We have our bone block up by the shoulder. We have a black suture tape that is our suture through the top hole. This helps guide us in and as a rescue suture. So if we need to bring the bone block back out, we have this in here to easily pull this back out if for some reason we need to. So we have this through the superior hole. Remember, the ink is on the superior aspect of the block. And now we'll take our mega loader and we will come through and at this point, I just take my retriever down that tiger link. I'm running the suture just to make sure there's nothing that it's tangled around, that hasn't tangled around the cerclage. And now we are ready to pass the cerclage from anterior to posterior. So you can see there's our tiger link. And there's our cerclage. They're going anterior to posterior. And now our cerclage are out the back. All right, so see, we have nice tension on the cerclage in the front. We have the slack out. They're even to each other. And we're slowly pulling them in until we get the bone block down to the obturator. Okay, so now we're at the point where we brought the bone block in. Here you can see the bone block, and as we pushed it through, and you can use a coker, but you have to be careful not to crush the articular surface or try to close it. So be careful with a coker. I like to use a combination of my finger to push it in and a coker, and then we bring the cannula out as it passes the obturator, and then we can confirm that we see at the top here. This is the top of the bone block as we marked it. So we know there's no way we flipped on ourselves, and our sutures look good. They don't look like they're twisted. And so now we can start to deliver this down. I'm going to come in the top here. And then we'll start to pull the slack out the back to deliver this in. And we're slowly just pulling, going back and forth, nice and gentle. And you can see down here, we probably have a little bit of that capsule and labrum that's caught. So we're going to release that. All right, and then here we'll just show this was the most important part. And that's why we tell you to free up all the way to the bottom, because this always entraps your bone block. And once you free it, then it can key in there nicely. We're pulling on this traction suture that we have, and we feel that we are ready to start tensioning. So now we'll take out that black rescue suture because we don't need it. We're where we want to be. I'm going to free everything up. You see there's the muscle of the subscap. So we're happy, and now we're ready to start doing our tensioning. So now we're going to take the tiger tape cerclage to the FiberTape cerclage nitinol loop. We're going to pass that through. Pass that through. Here we go. And we want to keep these exactly the same. Okay. And then we have the knot. We'll slide it down by hand past the transition of the tape. They can get hung up, so we just do that by hand. And then you can see we have a knot here. And the most important thing is to keep these exactly the same. So I'm going to pull my side a little more. There we go. And you can see the blue now. I got some slack on the blue, so I'm pulling on the blue. Now those are about the same. So now we'll keep going down. Okay, these feel pretty good. So now we are going to do our first tensioning. We're going to take the FiberTape Cerclage through the tensioner. And it's really important here to run the tensioner all the way down to make sure you feel that that initial knot is down on the bone. And then we load this into the tensioner and just do our first tensioning before we've cut and thrown any more knots. And we go to about 30 to 40. And we're taking slack out of the system. Okay. And then we'll release. And again, we load this up. We run the tensioning device all the way down to the scapula. And we're taking tension out of the system, slack out of the system, and we're getting some provisional fixation. And already we're feeling that this is getting pretty solid, pretty stable. And now we'll take our scissors and we will cut. So we have 2 limbs for the Tiger Tape Cerclage. And we're going to throw a half hitch. And we'll mark and make sure we don't forget which one is our post. And once we feel we've hit the scapula, then we'll take the tensioning device again. We'll leave the post snapped. And we'll take our other suture through the tensioning device. And once again, we tension to about 30 to 40. And then we can throw another half hitch. Our snap is on our post, so we easily know which is which. And then we'll throw one more knot. No more need to tension. We're done with the tensioning. We just back this up with another half hitch or 2. And then we'll repeat that entire process with the FiberTape Cerclage. One of the important things is when you're throwing your half hitches, you're not used to throwing half hitches and taking a knot pusher over these tapes. So I think it's important to make sure that the knot pusher is over the knot and actually sliding all the way down to the bone. I think it could be easy to not be familiar with this tactile sensation and prematurely lock a knot before it gets down to the bone. So take extra time sliding the knot pusher over these thicker cerclage tapes to be sure that you really are over and pushing the knot all the way down. And again, here we're tensioning to about 40. And now we're done tensioning the FiberTape Cerclage, and we'll just throw a couple additional half hitches. Okay, and another thing you can do is take your finger down, make sure that you can feel, because you really can feel the knots all the way down. The knots are nice and taut. You're down on the scapula. I can feel that, certainly in the smaller patients, a little easier. And then the final thing is we'll take the probe, feel our bone block. We like the position. It's solid. We feel this is incredibly stable and very well fixed. We are pushing very hard and there's no micromotion. So we feel great about this. And now it's time to cut our cerclage tapes. Then we take this down, hit the scapula, back it off a little, and then cut. Now we're completing the surgery and repairing back our capsular labral complex. We place an all suture anchor at about the 6:30 position. We've shuttled this. We're holding the labrum in the capsule. We're pulling this up. And now we're doing our tensioning for our inferior all suture anchor. And certainly you can cut this now, or you can leave this, come back and tighten again or tension again after we placed our superior anchor. It's really up to how much you want to tension. And now I can see this is where I want my complex to come up to. This is where I'm going to shift to. So now we'll place an anchor right here. And now we have our superior anchor, all suture. We've passed and we've shuttled. We're pulling, shifting our capsular-labral complex, and now we're doing the final tensioning. And we have a nice solid repair of the capsular-labral complex. And so we're complete. We successfully passed our bone block. We've tensioned it and tightened it and have a solid fixation. We've repaired our labral capsular complex. We have nice tension in the system, solid repair. We're happy with this. We're happy where the humeral head is sitting centered. And I think it's really important to note, to aid in the ease of the case, is using the Arthrex S3 system, because if anyone may or may not have noticed, there is not one time during the case where we had to ask our assistant to pull hard, abduct harder, or pull on the arm. We have the lateral traction device here, which gives us lateral traction, pulls the head away from the glenoid, and we can just focus on working and doing the case at hand and not asking someone to pull on the arm, which is incredibly helpful. So thank you very much.